everyone. It's a dose of Dr. Drew.
It is indeed, and we are not taking calls today because I have a very special guest. It is Dr. Allan Schore. He is a part of the clinical faculty, Department of Psychiatry and Biobehavioral Sciences at UCLA. Volume of 6 seminal volumes that he has authored. I had the great honor of sharing the dais with him at the 20th anniversary of his Sentinel, his first breakthrough book, Affect Regulation and the Origin of the Self. The most recent volumes, Right Brain Psychotherapy and the Development of the Unconscious Mind. You're going to love this conversation. This is. If you ever wonder what is, a lot of theories flying around about psychology and how the human being works. Dr. Schore gets right to the specific mechanisms so you can sort of see for yourself. He is now also running the founder of the Right Brain Institute, created to disseminate the growing body of information about early human development, attachment, brain laterality research, relational trauma, therapeutic enactments, current research, and clinical studies on psychotherapy. Again, that new book is Right Brain Psychotherapy and the Development of the Unconscious Mind. The second book, Allan Schore, it's with 2 L's and an A, A-L-L-A-N, Schore, S-C-H-O-R-E, AllanSchore, oneword.com to find out more. Dr. Schore, welcome to the program.
Hello, Drew.
Good to see you. It is a privilege. So I thought what we would do is I'm always excited to expose people to your constructs on interpersonal neurobiology because they are foundational to understanding the human experience, in my humble opinion. So if you wouldn't mind, indulge us for a few minutes, just giving us your basic constructs on the breakthrough phenomenon of right brain to right brain communication. And I'm going to stop you a little bit because since I first studied affect regulations and the origin of the self, like it was some sort of scripture, I've spent a lot of years thinking more about this stuff, as I know you have, and I'll have sort of questions. So let's get to it.
Okay. Incidentally, the right brain and the first book, Affect Regulation and the Origin of the Self, is now in a classic edition, in the 16th edition, etc.
Crazy.
Very nicely cited, etc. As you know, also, I spent some time being the editor of the series of interpersonal neurobiology for Norton. The essential construct of the interpersonal neurobiology, you know, it's a two-person situation, is that essentially in early development and throughout lifespan, brains are shaped by their experiences with other brains, especially emotional experiences shape the brain. The second part of that is that brains align and synchronize their brains with other brains, which is how the right brain to right brain situation came up in the first place, et cetera. So what I've done here is I've developed this construct, especially as related to my theories of early development and early attachment, which would be the right brain to right brain communication between the mother and the infant, and then to use those as a basis for dealing with psychotherapy, where those same early attachment experiences will come up again in the therapy. And so I'm also talking about a right brain to right brain relationship between the therapist and the patient. In other words, what I'm looking at here is what happens in the relationship between the therapist and the patient beneath the words. That being the case, quickly let me give you a quick view over what we're looking at here. If you'll put that slide up, this is classic work that was done some years ago, whereby here you're looking at the attachment between the mother and the infant. Incidentally, this is a 3-month-old infant. And at that point in time, the infant and the mother are reciprocally communicating with each other in a turn-taking interaction. And the way, obviously, there is no speech at this point at 3 months. Broca's area, Wernicke's area, not even online. We know that the right brain is dominant in early development, and it develops before the left brain, et cetera. But what you're seeing here is that they are now beginning to form this bond of emotional communication. And if you look at the arrows, what you're looking at here, one arrow coming from the mother's voice to the baby, which would be the prosody of her voice, the melody of her voice, and the abilities of this child now to read that emotional melody in terms of different states, because it's going to be different in a joyous state than in a fear state. Second of all, you're seeing the eye-to-eye communication, which is central here, whereby this baby is now learning how to read the visual facial communications of the mother, in addition to the prosodic. And third, you see with the hands there, what you have is communication here between the mother's body and the baby's body through tactile, gestural communications. And throughout life, this synchronized turn-taking interaction will occur in both of them, and will be, because the right brain is in an early stage of development at this point in time, it's being shaped by these interactions, and they will go into autobiographical memory, and not semantic verbal memory, but nonverbal, implicit procedural memory, etc. And for the rest of the lifetime, they're going to be encoded in that right brain in an internal working model of attachment. And it's those internal working models of attachment that we're looking at to change.
If you don't mind, I want to quickly just dig in a little deeper on that. But you put the picture back up, Susan.
Yeah.
Which is Dr. Porges embeds some of that interaction developmentally in the 3 source nuclei of the vagus nerve.
Yes.
And the subsequent branchial pouches, which are literally where those parts of our face develop, where the major inputs, again, are vagal.
Yes. If you remember that Steve also talks about a right brain circuit of emotion regulation. So he also talks about the importance of the right hemisphere. And that vagal circuit, incidentally, is right lateralized, etc. So what you have here, that last photo is essentially a photo of Porges' social engagement system, which is there throughout life, and as you pointed out, is really the autonomic nervous system. And I want to say here, there is now a tremendous interest in the autonomic nervous system, also in terms of psychotherapy, because it's involved in creating a sense of safety. And here the safety is coming from the interactive regulation, because the mother is regulating this baby's state. If they're too low, she'll bring them up, like if it's depressed, or if they're too high, like anxious or stressed, she'll bring it down, etc. But the key to it is this two-person psychology of one brain to another synchronizes with another in these. Now this, for the rest of the lifespan, this is operating at all times, etc. You walk into the door, you see your wife. There's a look on her face. She says to you, "I can tell by the look on your face that you're in this kind of emotional state." We're always reading these states, and incidentally, if you give a human being a verbal communication and a nonverbal communication, they'll always read the nonverbal, because literally it's centered in the body. Mm-hmm.
And back again to that face-to-face interaction, Dr. Fonagy also has a specific sort of mechanism of that interplay where there's his mentalizing frame, that he also talks about there being a second-order representation of the primary emotional state of the body of the infant reflected in the face of the mom, and also in the vocal prosody that responds.
Yes.
Any more to be said about that these days?
Yeah. First of all, what we're talking about is that for the first 2 years of life, because again, the verbal functions are not going to come out until into the second year. But for the first 2 years of life, the right brain to right brain is the only thing that they have. Then at the end of the second year, it shifts with the growth spurt of the left hemisphere. For me, the mentalization is essentially a left hemispheric mechanism, not the right brain. It's a later forming attached mechanism, which is connected to words and narrative.
Interesting. But it accesses the same system, but it's overlaid by the left brain system.
Exactly.
Yeah.
And incidentally, there are certain points in time when we have to take that left brain off to be able to access this right brain.
And it feels to me, again, I hate to keep interrupting you. I know you're not through with the presentation yet, but all these ideas are occurring to me, and it feels like interpersonal psychoanalysis has taken some giant leaps forward because of your work. Am I reading that correctly?
No, you're right. You're right. Obviously, my work in neuropsychoanalysis, has been also a thrust of this, because just for the record, I've also suggested that the right brain is the psychobiological substrate of the unconscious mind. So all of this is happening unconsciously, implicitly. But yes, the major contribution of modern psychoanalysis is the relational trend. And here we're talking about the relational trend. Now, what I'm going to get into in a little while is this ability to synchronize with another brain, essentially is what this relational trend is. Let me just say, it used to be the major model was a cognitive model and a behavioral model. That's now shifted to an emotional model, but it's also shifted into a relational model. So now we're really talking about not just a one-person intrapsychic psychology, but a two-person interpersonal psychology, and a theory that can overarch both of those.
And I would even go so far as to say, I've always cautioned people, stop thinking about one skull. That's not the whole story.
As you will see, that's absolutely the case. You cannot understand any piece of human behavior without understanding the way they're always communicating with each other or miscommunicating with each other. You also can't understand psychopathology, because in all forms of psychopathology, there are deficits not only in emotional functions, but in these relational functions, this ability to form relationships with other human beings, because quickly, the second part of this whole thing is that, of course, sometimes it does not go well. And in those cases, we're talking about early trauma. As you know, I've used the term relational trauma. So when you have a lot of misattunement and no repairs going back and forth between these two brains, this right brain is going to be in a very different state, and it's going to be more of an insecure attachment than a secure attachment, et cetera. And the question of psychotherapy is, can we change the insecure into the secure? And how do we work with all kinds of personalities, whether it be avoidant personalities or anxious personalities, et cetera, et cetera.
And back to the relational trauma, I don't know how deep we want to go into the trauma stuff, but we certainly have, come through a period, I think, that's of extraordinary amounts of relational or interpersonal trauma. Bessel van der Kolk being one of the premier sort of voices about that. And I have found that on the addiction front, everyone's traumatized, and the ability to rebuild the capacity for affect regulation is one of the big goals. And of course, entering that frame where they have the capacity to develop that back and forth you've been talking about becomes the challenge. And that's, of course, because of the attachment phenomenon. Yeah.
What you bring to mind is this. First of all, we're talking about the changes that we've seen over time. One of the changes that we're seeing over time is that we're now thinking the relational mechanism are the mechanism of psychotherapeutic change. It's the relationship period that is involved in it. So the more we understand with the interaction and the relationship, the better we are, because the old model was insight was the key. Make the unconscious conscious with interpretations, etc. We now know that with early disturbances, let's say the personality disorders, right, or the psychiatric disorders, insight is not there. They don't have that kind of reflective function. They don't have the Fonagy mentalization function, etc. So really, the whole change mechanism is therapy. And I want to suggest that what therapists are expert at is in being able to form therapeutic relationships with a broad range of patients and to form it actually deeper in order to make the changes. Remember, we're talking here not only about the cortex, but we're talking about the subcortical areas. So we're talking about really working in the deep unconscious on these matters.
The deep unconscious, which is bedded in the autonomic nervous system in the body. And so that's where the interest in that becomes. Have you seen that new book by Bud Craig called How Do You Feel? It's a really interesting book about, when I was trained, we were told that the spinal thalamic tract was essentially pain and temperature. And it was sort of this vague sort of, now it looks like that is recording some real information that's somehow my heart, I know, has got, literally my heart, it's got to be coming from the autonomic nervous system into that pathway. Is there are people thinking about that right now?
Absolutely the case. Absolutely the case. First of all, what we're talking about here is working with emotions. And the emotions are directly tied up with the autonomic nervous system, especially on the right side of the brain there. So what you have here is the therapist is an expert not only at reading facial expressions implicitly, intuitively, etc., but also able to read his or her own body through these interoceptive, that's the term he uses, the ability not only to read what's on that face out there, but also your own bodily reaction interoceptively to that face, and then feeding that back to the patient, etc.
Yeah, every really good therapist I know has many, many stories of uncanny experiences in the presence of the other. Hearing music, smelling things, or pain in certain parts of the body, that if they listen to, and again, this is part of the magic of therapy, and in the right moment, share with the patient, can have profound meaning to the other party.
Yeah. Joe, I want to point out something else. On the matter of trauma, not only, let's say in a real disorganized attachment, okay, whereby you have a real disturbance between the mother and the misreading of the states, etc. Also, what the baby is learning is not only picking up the intergenerational trauma along the line through that relationship, but also picking up the defense against that trauma, which is dissociation. So there is a great deal of interest today in dissociation, which is very different than repression, etc. And really being a disconnect between the limbic system on the right and the autonomic nervous system on the left. So I want to say here that when we're talking about really disturbances, we're also talking about how to work with the dissociative defense, and the body is directly involved in that too.
Is it what you used to call somatoform dissociation?
That's one form of it. But remember that when the dissociation is not only within the individual, it's also a disconnect between the individual, that all of a sudden the patient disengages, shuts the body down, etc. And it's like there's no link anymore. And so essentially what happens here is the dissociation mechanism sits on top of the trauma to keep it out of consciousness. If you remove it, so to speak, and you move it carefully, so to speak, then you'll see what the affects that was shoved down into the unconsciousness can now come to the surface, be communicated to another human being, and be regulated. And we're now talking about the strong, intense affects, such as deep loss, neglect, and terror, et cetera, et cetera.
I have actually experienced things, and I don't know if you have a model for this, but part of what I have experienced, and I've heard other professionals talk about this too, is that it's almost like that dissociation includes a dissociated part of self, if that makes sense.
Absolutely.
That is sort of, and that piece is communicating with the world. It's just the patient in front of you is not aware of it. And as somebody who's sitting in a tuning, sometimes you get that painful dissociated part and you can bring it into the room. Do you have a theory about how that lack of integration, that disintegration literally develops?
Well, it starts off in the attachment. Essentially, what we have here is a working model that is rather ineffective, and it's encoding that when there is stress between the person and another person, all of a sudden this dissociation kicks in. It cuts them off from their own consciousness of their body, but literally it'll be there whereby they're emotionally disengaged at that point in time. You cannot make changes in trauma without working with this dissociative defense, et cetera. And essentially, the more that it's loosened, the more capacity there is then to integrate these these split off experiences into the personality.
But these split off pieces, I've always wondered what was. I've not seen. I remember you had a theory at one point that the vagal nerve was mediating that split off piece through some cortisol surges or something. But do we have actual, like, since like I'd say last you and I spoke, a lot more data about the wiring of the brain has come in. And does anybody have any data on what's really going on there?
Yeah, and plus that data is in the hands of clinicians right now. But essentially the idea that I came up with is that the dorsal vagal, the early dorsal vagal system is operating during the dissociative state, as opposed to, which has no connections with the outside world, et cetera, as opposed to the ventral vagal system. So here, these people under stress, instead of using the dorsal vagal system to communicate their distress to somebody else, will operate with this dorsal vagal system and then just shut it all down, et cetera.
And so just to fill that in for people, the vagus nerve is a cranial nerve that is the major source of parasympathetic information coming out of the brain into the body. It's also the source of the information coming back to the body, something most of us weren't trained on in medical school at all, but Dr. Poor just pointed that out to us. and it develops as you're growing up, in addition to being right lateralized, some more of the right brain to right brain stuff, and it's embedded in our face, and we even can tune our ear muscles to prosody in a mom's voice. We have all that. That's all autonomic. That's not conscious. It's autonomic. But we are born with this dorsal vagal complex, and we sort of later develop the nucleus ambiguous, the ventral system. Right. Am I getting that right? Yeah. And the dorsal system is something we share with essentially reptiles. That it's something that reptiles use. When you scare a lizard, it freezes. We have that same system. We just pile things on top of it evolutionarily, and it comes online as we develop.
This is the ultimate defense mechanism. This is the escape when there is no escape, et cetera. Yeah. Absolutely the case, right.
Okay, so there's the basics. Let's start talking about your newer books. Where would you like to start?
Okay, let's start with the Right Brain book.
Okay.
The Right Brain book, incidentally, is, although I have talked about clinical applications all the way through, the Right Brain book goes more deeply into the clinical applications of the theory, than anything that I've written before. What I'm going to show you here is there are certain other new trends that are occurring in psychotherapy that I want to point out that are really important. One of those trends is called the trend of interpersonal synchrony. Mm-hmm. That there is a synchrony between the physiological state of two people over time, et cetera. And there's also a synchrony in their autonomic nervous systems. Incidentally, Drew, when you were talking about the autonomic nervous system, you're talking about involuntary behavior. And really what we're talking about is how one changes involuntary behavior, not overt behavior, which is why the old behavioral theory, is problematic. Yeah. But in this interpersonal synchrony, what you're looking at is, first of all, the term synchrony comes, no, not that one.
The other brain-to-brain one.
Not yet. I'll tell you when.
Okay, not yet. Not yet, Susan. Not yet.
Not yet. Synchrony means occurring in the same time. So now you have two people who are physiologically synchronizing their states with each other, like the mother and the infant, et cetera. But they also may be synchronizing their facial expressions, et cetera. And this occurs in reciprocal turn-taking interactions, nonverbal communications between two people where they're synchronizing with each other.
I'm going to interrupt you because I want to point out to people that if you don't understand this, watch a baby and a mom together. Yes. Literally, none of their faces synchronize. Their pupillary hippus, their pupils start moving together at the same rhythm. Their heart rate pairs up exactly. It's uncanny, and we are wired up for that from the moment of birth.
Yes, we are wired to connect, and this comes to the relational functions also. But in addition to the idea about about synchrony, this is literally by synchronizing with the patient. This is how literally we can read the patient beneath the words, et cetera. And there have been studies, Drew, as you know, also in psychotherapy, that in a session, their heart rates will synchronize together, et cetera. Yeah. Their autonomic nervous system will synchronize together. So the question is, here the therapist is using his own body in order to make contact with the body of the individual also. The synchrony also is interpersonal synchrony is also something that occurs in addition to the verbal exchanges. So interpersonal synchrony is a right brain to right brain ability to sync up. Go back to what you're saying here. In other words, the metaphor would be, and it's a literal metaphor, to be on the same wavelength as the patient, to be in sync with the patient, et cetera. And you see a lot of this, especially in intimate couples, et cetera. But now the ability of the therapist to synchronize his internal physiological state with the patient's internal physiological state really is an important bond, because the internal physiological state is the arousal level. And essentially what we are regulating, we are down-regulating the arousal level. When there's terror, we are up-regulating the arousal level, et cetera. So we are matching the autonomic rhythmic patterns of the patients in our own body. And then as they come back to the patient, et cetera, they can come to the surface, and then they can be regulated. And again, the regulation is going to be implicit regulation, intuitive regulation, and the key to the dysregulation, et cetera, would be the therapist's ability to regulate the patient's state.
I notice you don't talk about frames very much, the frame in which that happens. Is that just not a word that you find convenient to all this theory?
How do you?
Well,
do you think
to me, I don't know. One of the things I think the therapist needs to be able to do is create a safe frame of interaction and hold the frame. It's old. What was that guy's name? There was it's almost coming to me. There was a famous psychoanalyst that always talked about holding a frame, and I find that sort of, and maybe just my own head how it works, but I find that an important sort of aspect of getting somebody into that frame, making sure the frame is safe, and holding the frame while that interaction occurs. You know what I'm saying? So I don't exit, I don't leave them, I don't abandon them from the frame, and I'm in the frame with them. I guess is the important thing.
You're in the frame with them. I want to suggest to you that, first of all, we don't create the frame, we co-create.
Right.
We don't create the attachment, the relationship. We don't even create safety and trust, which is critical. We co-create that. So both of us literally are part of that kind of a situation. But I want to suggest also that there are times when we break the frame. Then literally we go into the state with the patient, because the only way to regulate the state is to be in the state itself. And we're now seeing more and more the idea about mutual regressions, whereby the patient and the therapist both shift from the analytic left into the autonomic emotional right. And in that state now, the patient is reliving the trauma and enactment with the therapist together. So if you're staying up in the left, just interpreting, that's not going to make it. There are times literally when we break the frame.
I get it. Beyond is who I was trying to think of. Beyond's frame. Okay, so continue. We're going down your path here in terms of therapeutics.
So let's take a look at this next thing. The
slides.
Is
that correct?
The one in the patient
in the lab. In the lab. The lady's hooked up.
Yeah.
And Jordan, if you have any questions here, let me know. So bring in.
Okay, here we go.
Okay.
All right. What I want to point out here is that this idea about the right brain to right brain mechanism has been there for 25 years, et cetera. And it's really been adopted greatly in the clinical community, et cetera. But in part, we have to go. It's a two-person psychology idea, and we have to go past a one-person psychology measure in order to get to that. I want to point out that for the first time now, we have hyperscanning studies, hyperscanning research, in which both brains of a dyad are being measured at the exact same time while they are in the midst of a reciprocal turn-taking nonverbal communication between each other. And essentially what this is although this hyperscanning has been around for some time, in 2018, the first study came of going into a laboratory whereby now you have measures on both brains as they are involved in going back and forth, essentially talking about emotional situations here. In this case, what we have is near infrared spectroscopy used at the same time when they are engaged in this dialogue, et cetera. Now, what you have here is two people getting together, and essentially what they are doing is, in this typical psychotherapy session, is that they are discussing emotional issues. They are also discussing developmental problems that the patient has had, et cetera. And the focus of this treatment between these two here, and this is done in China, is on the emotional states and the personal troubles of the patient, et cetera. In this situation, as you can see, each is observing the nonverbal facial cues of the other. So this traffic, just like in the first Trevarthen figure there between the mother and the infant, this traffic beneath their verbal dialogue are these nonverbal expressions, and the therapist here has been trained literally to be able to read the nonverbal cues, the face, the voice, and the gesture. Now, ultimately, what they did then is they took, a scan here to find out what the changes were. And I'm going to suggest here the striking thing is that the changes here, you would think that because the therapist is doing one thing and the patient is doing the other, that the therapist is leading to the changes in the other's brain. But that's not what they show. What they show is that there are changes in both brains. Now we're talking about the relational aspect of things.
Yeah.
Over the 50 minutes of this psychotherapy session. Now go to the red image.
Here we go. We're getting there. There we are.
This is the image. Now watch. What you see here is a top-down view of the brain. So what you're seeing here is that all that is showing here is a communication, a right lateralized communication between the posterior areas, the purple areas, the red areas in one brain to the posterior areas of the other brain.
On the right.
On the right. So here what we have is a right lateralized interbrain synchronization during the psychotherapy situation that's communicating emotions, etc.
And Dr. I'm guessing the colors mean something. What do they mean? That they're synchronized in terms of wave function, or what
yes,
is that? Yeah,
they are synchronized. They are synchronized in terms of activity.
Yeah,
that the activity of the on the left in the right hemisphere is absolutely synchronized with the activity of the right hemisphere in the other, and also the posterior areas which are leading to these are involved in face processing, voice processing, and incidentally, they are also involved in these are the areas of the brain that are involved in empathy and also in making sense with another mind. So here, notice what you have is a right lateralized synchronization between the two, which incidentally is what I have termed for 30 years now, a right brain to right brain communication. What I'm suggesting is true. Now we have the ability through this hyperscanning to actually validate this right brain to right brain communication model.
You also privilege the orbital frontal system as sort of the central processing point in all this. Is that still borne out through this?
That is, although what we're looking at there is more in the first. This is a session in which the patient is now coming up and laying out his personal situation there.
Yeah.
What's happening at that point in time is that the therapist is not regulating anything at that point, just making the person comfortable enough to be able to open up and to engage in a very personal conversation about themselves. Notice the first session this is the first session of a psychotherapy. It's not taking a history. It's literally allowing the patient to feel comfortable enough to be able to now in emotional terms, not talk about the emotions, but communicate these emotions to others. Later, when the therapist is regulating, then you'll see the frontal parts of the right brain, as opposed to these posterior parts of the right brain, which are the communicating parts.
Okay, so that the way I think of it is, one is more the attunement, and the other is offering some soothing affects in response or something.
One is communication, one is regulation.
Regulation. But I always feel like, to some extent, attunement has some regulatory component to it. I mean, the patients kind of meet the therapist to some degree.
Yes.
Yeah.
Incidentally, another synchronization is another term for attunement. So, but I'm just suggesting here, yes, there has to be a communication of the emotion, and then you have the interactive regulation of the emotion. So they're both in the right brain. The point of it is, if you go back to that image real quickly, notice what's happening in the left hemisphere over the course of that communication.
This is
the left literally is absolutely doing nothing.
Huh.
It's all right to right, etc.
And these are EEG,
This is near infrared spectroscopy.
Oh my goodness, great! Is anybody doing
They
fMRI?
also use dual EEGs also.
Got it. Is anybody doing fMRI and things, that sort of stuff?
Yes, but fMRI are more problematic because the sound, etc. These are portable things which are right on the head, etc. So they're non-invasive, and you can have a very normal, natural situation.
I get it. I don't know how you would do it with fMRI, but I'm just sort of interested in what's underneath, what's going on in the subcortical structures and things. It's sort of be fascinating to know.
So essentially, I want to point out here that in this study, not only did you see this right lateralized synchronization, but they had subjective measures of the patient's attachment at that point in time and the level of the attachment bond between the two of them. This synchronization is how the attachment bond is formed between the two of them and how the therapeutic alliance is set up. One more study, which was done in 2020 by this lab, now studied expert clinicians to see if there was it. And they found that what expert clinicians with experience are able to do is they can form a stronger bond, a stronger synchronization bond over,
a shorter period of time, like right away.
And they can do it with a variety of patients and at a deeper level.
Okay, so that actually fascinates me because that's sort of what I've seen out there in the world, which is there's a range of capacity for this kind of work. Some people don't have any, sorry to say, and they can do cognitive behavioral therapy and still be kind of empathic and things, and there's a place for that. But this deeper work, which I think is the real change, and certainly particular for people who've been traumatized, I guess my question is, are people being better trained at this these days? Is the mental health world more open to, really getting on board with all this?
Well, let me put it this way. To my mind, you heard part of the answer to that. To my mind, the key here is that there is an overemphasis on techniques.
Yeah. Yeah.
And what is being taught of these techniques. But all of these techniques sit on top of the capacity to form a relationship, which was why with one therapist using a technique it works, with another it doesn't work. Essentially, this study came to the conclusion that people, as they train people, they should be trained in how to work in nonverbal relationships.
Yeah, and I have a sort of a rush of thoughts as you say that. One is that there's all that research out there about the outcome studies were dependent not on the technique but on the empathy of the therapist, and I don't think that empathy piece was broken down properly. I think if they broke it down, they'd find this material underneath as the really important piece that they just sort of called empathy. Yeah.
Drew, I'd also suggest there's a difference between cognitive empathy in the left hemisphere and emotional empathy in the right hemisphere.
Yeah.
Cognitive empathy is an intellectual understanding that the patient needs more than an intellectual understanding. And incidentally, sometimes an intellectual understanding can be a severe misattunement.
And I completely agree. And I have to tell you, out in the 12-step world, the relationship with the sponsor, when it's a good relationship, is somebody sitting across from the identified addict, the person who's doing the sharing, just sitting across and listening actively with their whole body and saying things pretty much only, I understand, me too. That's about all they say, and right. As a lot of material flows at them, and that helps.
But all that they're saying, literally, the tone of the voice is there. The gesture is there, so to speak. They are using their whole body when they are giving these communications back.
Yes.
So just using really doesn't get across the idea.
Let me ask this. This is a crazy question too, which is, we're talking about professionals who are highly skilled and, really good at doing this. But do you feel that sometimes people can access this sort of healing phenomenology in their relationships? And in my sense, if that's true, they have to be around people that are not their usual fittedness, if that makes sense. Do you understand what I'm saying? That I've always thought people could, because I see it in 12-step all the time. But they are around people that are not traumatically reenacting in any way. They're people that they wouldn't necessarily be attracted to go fit with. They're just people who are just truly present, but aren't their usual, profile.
Yeah, again, I just suggested that one of the findings of that latter study was that they can form relationships across different types of psychopathologies and different individuals there.
Yeah.
And again, that ability to be able to do that, and that ability to also to resonate with different emotional states, et cetera, I think is something that is learned over the years, et cetera, because in the end, all of that is not done consciously and deliberately by the rational mind. It is done intuitively. And in any profession, When you get to the level of high skill, you're talking about people who have intuitive capacities. And I want to point out the mother, literally, the secure mother, intuitively is reading this baby states also. So we learn how to do this. We can do this even better with time and with experience.
I had concerns about all this Zoom stuff going on during the pandemic too, because you don't have the body-to-body communication so much. And yet I was sort of surprised that Zoom was as effective as it was for as long as it was for a lot of people. What are your thoughts on
that? I think that, first of all, let me say there are two forms of psychotherapy. One symptom reducing and the other one growth promoting. We're actually changing the personality.
Important.
I think that you can't do the latter in Zoom.
Right. I agree.
But I think that you can do some symptom reduction on Zoom. That being the case, I also want to point out there's something abnormal about this. The faces are too large.
Yeah.
And they're too close, etc. You think now about the distance we usually work at. That distance is about 6 feet, etc. And you don't have a huge face in front of your screen.
Right, there. Right.
So ultimately, I think that we need to go back to a real live body-to-body, face-to-face situation.
I totally agree.
And I think that we will as soon as things become safe.
I completely agree.
How about if we take the masks off too?
Oh, well, that's another question. Do you feel, what about child development and the mask wearing? Do you have any concerns about that, or will we catch up? Any questions? No. Okay.
I think we'll catch to that also. I mean, the mask is also interfering there.
Yeah.
But on Zoom, of course, you don't really need the mask.
Well, I'm thinking more about child development with the out in the world and interacting with humans and whatnot.
Yeah. Well, let's say in the cases of a 1-year-old infant, that infant literally needs to come really close up to that mother's body. And I think that some of these things are interfering with that capacity. And ultimately, if the right brain really becomes problematic, what you're going to see is not only problems in emotional regulation and in relationships, you're also going to be seeing problems in intimacy. Right. I think that therapy also is about co-creating intimacy with an individual and learning to be in the world with other people in an intimate way.
I completely agree. That's for me, again, that notion of a frame, an intimate frame. And let me ask a big, broad philosophical question, not to get you off track, but I wondered on your thoughts on this, because you made me, you were instrumental in me getting out of the one skull construct into two skulls. I started thinking about the phenomena of consciousness itself. And I started thinking that, if I were a feral child lost in the woods at age 2 and came out at 14, I don't think not only would I not have a self, I would not be able to regulate. I don't think I would have consciousness in the sense that we think of consciousness. Have you given any thought to how this interpersonal neurobiology and seeing ourselves reflected in the other gives us some sort of autonomous reflective capacity for this thing we call consciousness? Yeah.
Although I want to point out here that really the idea of unconsciousness is critical also, et cetera.
Yes.
But yes, I just showed you that Trevarthen, that with that 4-month-old. At the same time period, Ed Tronick, I don't know if you're familiar with the name Ed Tronick, who was at UMass, et cetera, for years, who was studying synchronization, et cetera. He came up with the still face.
Okay, this is a special test. This is the attachment theory.
Yeah. But he says that essentially at 4 months, 5 months, the baby and the mother are sharing a dyadic state of consciousness between them.
Interesting.
So this ability to have these states of consciousness also is directly affected by the relationship between one human being and another, in this case, between the parent and the child also. The ability to have these states of consciousness also comes out of the attachment relationship.
Yeah, I think that when people theorize about consciousness, they must take this into account. A single brain explanation will not do it. All right, I think now we haven't gotten to the second book yet, have we? Or have we?
No.
All right, let's talk about that book. That book is the development of the unconscious mind. So we've talked about consciousness. We've mentioned the unconscious mind and the bodily-based experiences that are attuned and intuitively sort of shared. Let's talk about the development of that.
Okay. A number of chapters here in this book. The first chapter bears directly on what we're talking about. The title is The Early Emotional Attachment, the Development of the Right Brain, and the Relational Origins of the Unconscious Mind. Okay. Remember, there's been a privileged state to this consciousness or reflective consciousness, et cetera.
Yep.
But here the attachment is affecting the ability of that unconscious mind throughout the lifespan, but also to experience dyadic states of consciousness and to share states of consciousness with other human beings also, et cetera.
Boy, I had not constructed it that way in my head, separating the conscious and the unconscious in terms of the shared experiences. That is a profound thing when you start thinking about it. It has lots of philosophical implications and developmental implications, perceptual implications, all kinds of stuff. Is that you think about that in the book?
Absolutely.
Yeah.
Absolutely.
Wow.
Drew, what I'm going to have my publisher send you both of these books.
Please.
But that being the case, let me tell you, the third chapter is called Early Interpersonal Neurobiological Assessment of Attachment and Autistic Spectrum Disorders, where now I'm applying in my developmental work how we assess autism and how we differentiate autism in the first year from disorganized, disoriented attachment, which is a very important differentiation to make there also, et cetera. The fourth chapter, All Our Sons, the development of developmental neurobiology and neuroendocrinology of boys at risk, it really addresses the problem of why are boys at risk for externalizing psychopathologies. As you know, females are more towards internalizing psychopathologies. And in that, I offer information starting out that there are differences, now documented differences between the male and the female fetus, and that literally the right brain develops more quickly in females than males. And because the development of males to the maturation of that right brain is slower, they are open and more vulnerable for longer periods of time in the fetal life and into the first year also, et cetera. So these are just, some developmental pieces on it. Then there are other chapters on one more I want to mention here would be the title, The Development of the Right Brain Across the Lifespan, What's Love Got to Do with It? Which essentially is my ideas about the evolution of love being a strong, powerful emotion, et cetera, and how the love between the mother and the infant really sets the stage for the capacity to enter into loving relationships at all later points in time. And that incidentally, when it comes to the emotional experience of love, that is quintessentially a right brain experience also, et cetera. So that book has more to do with my developmental studies as opposed to the right brain, on the therapeutic.
I'm guessing you're sort of locating love also in the vagal input from even the heart, perhaps, as well as I imagine the orbital frontal figures into that rather prominently.
Absolutely the case.
Yeah.
Remember, for years I've been talking about the limbic autonomic system, the limbic/autonomic.
Yep.
So now you have the limbic circuits of the orbital frontal, the cingulate, the amygdala, the insula. The insula you talked about earlier.
I did.
Also, so to speak.
I did not bring it up, but I was referencing a book about it. Yes, and the insula has sort of jumped out for me in recent years as something. So the insula is a region of the sort of cortical structures, sort of cortical, subcortical. And, there's a homunculus on our brain, right? Our sensory and motor homunculus, a little thing that sort of maps out our body. Turns out we have the same thing in the insula, and it goes from anterior to posterior, and it's lots of cuts of our body, sort of feeling states, right? Am I getting that right? It's crazy to me that when I started realizing that's how that was constructed, and if I'm getting the neuroanatomy right, it is right next to the orbital frontal system, is it not?
It's directly connected to the orbital frontal system. Absolutely the case.
So there it is.
So here we're talking about, again, the body. And incidentally, the insula has deep connections into both the parasympathetic and the sympathetic, et cetera.
Yep.
So I want to suggest here, if we're talking about psychotherapy, we are now talking about more than working with the mind. We are talking with the mind, working with the mind body. And we are using our own mind body in this situation to alter the states of the mind body also in the other.
I'm going to interrupt for a second. I've got someone on my chat here that has a specific question you may or may not feel comfortable answering. I think the autistic spectrum conversation brought this out. So a child is experiencing autistic spectrum behavior, but also severe ADHD. Is it correct to introduce medications to treat ADHD before a complete psych eval if a child is suffering? Boy, that's a loaded question. But let's say, I guess the question would be, treating the ADHD, would we interfere with the ability to assess fully the autistic spectrum?
I don't think so.
I don't think so either.
I think that they're existing situations, but they have very different etiologies.
Yes.
Incidentally, the autistic spectrum, clearly the etiology goes back to the fetus even before what you just saw there between the mother, and so it's a much earlier situation.
Interesting.
Incidentally, what you have in autism is an inability to synchronize with other human beings also.
Yeah, I've been thinking a little bit about that and that population and how challenging that must be for them to regulate.
Right, because there is such a limitation on the inability to interactively regulate.
Yeah.
You have to fall back to auto-regulate.
Well, now let's an interesting question. My sense, and I have no evidence for this, but my sense is that interactive regulation really precedes effective autonomous regulation.
Absolutely.
Yeah. And so if you have trouble reading social cues, meaning you're not picking up all those subtle things we talked about, the little facial musculature in the ear, the prosody of the voice, it's got to be tough. And it makes me, I always think maybe that's why some autistics are so dysregulated. They don't have that interactive capacity.
Right, and that's different than ADHD, because in ADHD there still is a capacity to take in the interactive regulation, to take in the comfort, the interactive regulation. But in autistic spectrum disorders, that's not there, and it's all a matter of auto-regulation. And incidentally, that also will lead to a higher capacity, higher ability to dissociate.
Right, which is
because
again,
the ventral vagal system is also going to be somewhat compromised.
Right, because your body does what it does, and it will regulate, and when it gets all the way through the higher systems, it kicks into that dorsal vagal system. Yeah. Did we make it through the book? Have we said everything there's to say about that?
Yeah.
Did you? I'm gonna pull you back in the development of the unconscious mind again to. I'm going to have to think about this for a long time, and of course I'll devour your book as soon as I get it. But it makes me immediately think about philosophy and the nature of the unconscious mind and what the implications for that are for the human experience. I don't have a fully formed idea yet about this, but I'm wondering if you think about those things and if you have something to say about that.
Yeah. The first image that I showed comes from Cole Wintervarthen, who is in Scotland, and he worked with Sperry in split brain research, and he developed this idea of intersubjectivity. That was what you saw there, was intersubjectivity, because essentially what you're seeing is the ability also to read each other's minds, etc.
Yeah.
This situation, which comes up at 3 months, these two individuals are in a high state of joy. They are in a positive emotional experience. The dopamine systems are very active as they both enter and share into this state of joy. 3 months. I just wrote an article of this in Frontiers in Psychology, in which I'm suggesting this changes our whole idea about the early development of the unconscious and really what is at the core of the unconscious. At the core of the unconscious is not Freud's drives and cauldron of drives. What's at the core of it literally are these very positive, loving connections between the mother and the infant. That's a very different idea of how we see the unconscious mind, et cetera.
It is different. And I like the construct, because I've always felt that I think what Freud was looking at was motivational systems. And motivational systems influence mind, but they're not source of mind, if that makes sense. Right? I mean, if I have a very powerful hunger, appetite of one type or another, it affects my arousal states, and it affects my priorities. It doesn't affect my being. It doesn't affect who I am. right? I mean, I guess it could at some point if I made choices based on motivational states that were disruptive, but I don't know.
No,
I like taking motivational states away from that core. Really,
Yeah.
you're talking about a self-experience, the experience of the self in joy.
Yes. According to Bowlby, attachment is a motivational system.
Yeah.
And that motivational system is a system to connect to other human beings emotionally, et cetera.
Yeah.
So you cannot have a self system without an emotional core to it, a right brain emotional core to it.
Yeah. So we have a drive to make that connection that we saw in that image, and the image is the core function of joy and positive affect. But to be fair, it's that tender open experience that is shattered by trauma.
You got it.
Which is what makes trauma so painful.
You got it.
Interpersonal trauma.
When things really go badly, like an abuse and neglect, what is shattered is the ability for safety and trust in another human being, et cetera. And safety and trust are going to be part of all intimate relationships. Incidentally, on the matter of the unconscious mind, and the other aspect of the unconscious mind, Hewlett Jackson, the great English neurologist in the 19th century, called the autonomic nervous system the bottom of the unconscious mind.
He was right. He developed somebody with his name developed the concept Jacksonian dissolution.
That's it.
Which is as we develop evolutionarily, we don't necessarily lose ancient systems. We pile things on top.
We build on top.
Yeah, and then we go through those systems as they fail us, and we sort of will end up in deeper systems if the top systems fail us. Which is fascinating.
Incidentally, which also bears on the idea about regression.
Yeah, absolutely. I think regression is sort of perhaps needs a modernization, doesn't it?
Well, here's what I'm going to tell you. I think it is.
Yeah.
I think that what we're looking at, that regression is a colossal shift. It's a transient reversal of hemispheric dominance, whereby it goes from the higher left hemisphere down to the lower right brain, et cetera.
So in a way, that's a Jacksonian shift too.
Yes, it is.
Yeah, very interesting. So
Jackson also was involved with the ego over the id. That also was a Jacksonian.
I did not know that.
Cortical over the subcortical.
I have two last questions for me. One is when the joy is disrupted in trauma, is that typically result in longing for reattachment, but no ability to make it? If that makes sense, I guess that's. Maybe it's narcissism or other things that we have other names for that, but I'm imagining that sort of some sort of longing would be left behind by that.
I'm thinking that literally what can be dissociated is not only terror, but also joy. In other words, the attachment system itself can go underground.
Oof, that makes sense.
And though a part of it literally is trying to reach out and to find some safety where it can make that connection.
Yeah.
But you've driven that underground.
Right. And it has sort of superficial / dysfunctional strategies because of the fear of that vulnerability again. Does that make sense?
Right.
Yeah.
Right.
And
that's going to be the core of the difficulties in making relationships.
And then yet we do this crazy thing as humans, which we have traumatic reenactments, which in my experience are based on, people don't think about this very much, but it's based on attraction to the people and circumstances that are very similar to the original perpetrators. Any more to say about that these days?
Let me give you a real fast one on this.
Yeah.
In terms of the changes that we're seeing in the psychotherapy world, there is now a tremendous interest in reenactments of relational trauma and working with these reenactments. We now realize that these are not technical mistakes of the therapist, and they're not due to the acting out of the patient, but literally these are possibilities for new growth and development and for integration, et cetera. And therefore they become very important moments of the treatment, et cetera. And what is being reworked in these reenactments is the rupture and the repair. Because remember that what trauma is, it's the rupture without any repair, et cetera. So essentially the rupture and the repair in these reenactments is now seen as a major mechanism by which the individual can change.
Could you give, just so people understand what you're talking about, an example of that kind of an exchange? Like somebody has some sort of traumatic reenactment, you hate me or I hate you or something. And yeah.
Let's say that this therapy has been going along fairly well and the patient is now feeling more and more safe. At a certain point in time, they will feel safe enough to lessen the defenses and let what has always been dreaded below to come to the surface. Now, that's not being done by the left hemisphere of the conscious mind. So what you'll see is that all of a sudden, it appears nowhere. There's a shattering of the therapeutic alliance and a shattering of safety and trust at that moment in time. But on the other hand, this allows now for this piece of psychopathology to be out there between the two of us,
yes,
et cetera. And essentially now it allows for both the patient and the therapist together to re-experience the trauma and then to come up with a new corrective emotional experience.
I know as somebody sitting on the other side in those sorts of experiences, I feel a lot of anxiety when that happens. I fear of doing the wrong thing, fear of, hurting the person. It can be a very anxiety-provoking thing for the person experiencing it.
Yeah, these are the most stressful moments of the treatment.
Yeah.
The technical literature is now reading that there's an equal problem in avoiding the enactments.
Right. Yeah. Which makes sense. I mean, your brain does that naturally. The therapist's brain. That's you don't want to be duplicitous, but we have our own stuff we bring to the room. For sure. And we have
this takes the most skill.
Reading it constantly. And then, and by skill, you mean lots of experiences doing it in lots of different interactive contexts.
Yes.
Yeah. Okay, Dr. Schore, I think we've run the cycle. Single, double, triple, homer. We got it all.
People love this.
Yes, they do. They should.
Let me just throw in a little pitch at the end here.
Yes.
The Right Brain Psychotherapy Institute, which is now online, worldwide, et cetera. As you're well aware, for many years, I've had study groups with here in LA, but also around the world, Australia, et cetera, et cetera. The Right Brain Psychotherapy now provides videos of master classes with me and these groups talking about enactments, et cetera, talking about, new things that are coming up in psychotherapy, et cetera. And that now is online and available, rightbrainpsychotherapy.com.
We actually have it. I don't know if you can see it. We have it up on the screen here with us. And I always have more and more thoughts when I'm talking to you. Are you using this or training people on how to apply these same techniques to group settings?
Yes. In fact, I've written an article on reenactments of attachment trauma and dissociation in group psychotherapy, published in the International Journal of Group Psychotherapy. I can send that one along to you.
I would love it. I think group is a really interesting place to be practicing these kinds of things. I think that takes in a special professional. Yeah. That person has to be an antenna of everything going on in the room with their body.
Remember for so long now, when we had a patient who was stuck and literally, even though that they were making improvements in their symptomatic behaviors, they were still having relational problems. We would send them to group, and the group is a powerful matrix for those kinds of changes also.
Interesting.
And incidentally, using the right brain to right brain model also.
It's very, for the people that are listening to us, it's very powerful to run groups if you use your mind and body as a receptive regulator. It's so much of this is uncanny. When you get into it, it's really quite powerful, and you can literally feel stuff going on behind you. You literally, if you're attuned enough, you'll be like, okay, this is the patient over to my right. I don't know what's going on, but something is going on over there while this patient is talking and expressing something. And that's the power of that dynamic you can sort of create in a room like that.
In individual psychotherapy, the change mechanism is the therapeutic alliance. In group, it's cohesion.
Oh,
and
interesting.
essentially the whole group can act as an interactive regulator.
Right.
And that's a powerful source.
And you have to build that shared common sort of appreciation of each other's experience before they can start to do that for one another. All right, Dr. Schore, as always, it is a deep honor, quite a privilege to speak with you. I can't wait to devour your newest stuff. Susan, Right Brain Psychotherapy, you have the book up, and the other book is Development of the Unconscious Mind, which I cannot wait to get into. Are you speaking anywhere coming up? Can people go somewhere to find you?
Everything that I'm doing now is on Zoom, Italy, England, et cetera, at least for this period now on Zoom, et cetera. So I have been off an international flight now for a year and a half, and I'm not unhappy about that.
Are you going back out soon?
Yeah, I'm afraid so. Yes.
Well, listen, I'd love to
vaccine.
tag along. It gives us an excuse to go somewhere. So keep us in the loop with where you're going and what the context is. I still, my son's getting a psychology degree, and I made him listen to the tape of a lecture you delivered. I think you remember it. UCLA, like 20 years ago. Susan Solomon, was that her name? Set it up. Do you remember this one? With you and Fonagy and Dan Siegel and even
God, how do you remember all those names?
Oh, and even Stern was there.
That's right.
And to me, that was one of the most. That to me was like the gathering of the gods. I was like, oh my goodness, what? It's like that was a long time. That was 20 years ago, wasn't it?
Yeah. Listen, Drew, it has been an absolute pleasure. Our relationship really goes back quite a ways, et cetera. And it's absolutely a joy. And once again, the bouncing the back between the two of us is just a joy.
I love it, and I carry the word forward, so you can count on me. Dr. Schore, thank you so much, and thank you all for listening. And we've been watching you guys on the restream here. Thank you for all your questions, and that'll do it. We'll see you next time.